Great talk, Mohanad. I'm going to show you what happens when you don't follow the steps that were just outlined by Dr. Mohanad. So this was a supposedly straightforward non-STEMI with a culprit in the RCA. The lesions were distal, mid, and proximal. So it was ballooned, IVUSed, and IVUS showed that the disease is really extensive. So more balloons, more lesion preparation, and the decision was made that it's going to be a long stent. The RCA is going to be covered from essentially the proximal segment all the way down. A first relatively long stent, I think it was 30 or 34 millimeter, was delivered, a little bit of a struggle, but with a femoral 6 French JR guide, the operator was able to deliver it. The second stent was coming in, and you could see here, it's really not going, a lot of trouble, a lot of struggle delivering it. Now, this is a 48 millimeter stent. So it was pushed again further, and it did not cross the distal stent. So there was no overlap. It was pushed again and again, and really there is no overlap yet. If you really look closely, and no one noticed this in the beginning, if you look at the first dot, the proximal dot on a Zion stent usually does not look like that. And for comparison, if you look at the proximal dot compared to the distal dot, they look differently. And this is, the stent has not touched the guide yet. This is not because of the guide. This is the problem in the graph that Dr. Mohanad showed. This is why the stent will interact with the guide as it comes back. So when we've all pushed stents in and then pulled them out into the guide, this is a different scenario. This is a different beast. I think if you see this again, deploy the stent. Do not take it back. Do not put a guide liner. Just deploy the stent. Leave the gap in the middle, in between the stents, and deal with that as a problem. That's another problem, but you'll have ways to deal with it. You could take a guide liner down there. It would be a much, much better scenario than what was done. So no one noticed this. We thought, okay, the thinking here is, let's bring it out, prepare that lesion in the proximal, in the distal RCA, Absolutely. I don't know if you can see my cursor. Yeah, I don't think you can. So it's the first dot. So for comparison, if you look at the first dot and the distal dot, there is no separation between the distal dot and the stent. So you could see that the stent is touching the dot. But here, you could see dot, gap, stent. And this gap is because of the interaction of the lesion with the stent as it's being pushed, pulled, so it's shortened, it's deformed. So when you pull it back, it will interact with the guide. And then you will apply more force and you'll make the situation worse. Deploying it here would have been a fantastic thing. Obviously, that did not happen. Before I move on, I want to also talk to you about decision fatigue, because decision fatigue is a big problem that we cannot recognize it. Decision fatigue is why supermarkets, they put the candies outside, because they've done studies on that. If they put the candies at the front of the store when you're coming in and you have not made any decision yet, their sales actually are lower than the candy at the door, because you've moved around, you've made a couple of decisions, now you're more likely to make poorer decisions. Judges make less decisions or more deference in the afternoon compared to the morning, way more than due to chance. Decision fatigue has been looked at extensively. Up until this point, the operator has made a lot of decisions. So going forward, they are much more likely to make poorer decisions or worse decisions. And that's why calling for help and calling for other people who might have been more fresher would help a lot. So here, the decision was, let's pull it back. So whoever did not notice the small gap, the gap is now huge. So this is the first dot, and this is a balloon without a stent. So this is the stent delivery balloon, but there is no stent inside the guide. And you can see outside, the stent is just crushed outside. And the distal dot is still right where it is. So here there was a clear recognition of the problem, and the decision was, okay, we still have more than half of the balloon on the stent. Let's just get out. Let's just pull it, take it out, and restart. So here you see that the stent is touching the guide. Everything is, quote unquote, controlled, and we are pulling, and we're coming out. We bring it out. The problem is it's a 6 and a 6. So it's a 6 French guide in a 6 French sheath. So the guide comes out, the sheath, the edge of the stent would not enter into the sheath. And that just makes you more frustrated. The whole plan was that it's just going to smoothly traverse through the sheath, and that did not happen. So, decision fatigue, decision fatigue, decision fatigue. The decision was, let's pull, and yank it. So we pulled, and what you're seeing is that jump is essentially the separation of the balloon off the stent. Here, the density is not really an inflated balloon. It's just a crushed stent, a 48 millimeter stent that is just very, very short. So we thought it will just come out. Next image, and all these images are from a contralateral side. So you could see here that we do have control of the artery. There is no bleeding. When there is manual pressure, we have good distal flow, but you could see some extravasation of contrast through the stent. So essentially, part of the stent is inside, very little part of the stent is inside the artery, and most of it is outside. Essentially, an expensive angioseal. And it really just plugged the hole. There was no bleeding. So there was very, very minimal oozing when you would let go. There was no need for mechanical manual pressure. We didn't like this lesion, and we wanted to really seal it, so we just put a balloon, inflated it, smoothed everything, made sure that we're compressing the artery, and whatever little part of the stent that was left, we just wanted to make sure that it's not sticking out in the artery and might cause future problems. So we just wanted to either push it outside the artery, or make sure that it does not cause endothelial injury to the common femoral artery. That's the final imaging of the artery, and it looks pretty decent. No bleeding and no extravasation. And this is the final angiogram, and you could see clearly that the stent is just in the tissue outside, not really in the lumen of the artery. Went back to the through the left femoral guide and took 2 shorter stents, prepped the lesion very well, overlapped them, and the procedure was completed successfully. So, take-home messages are: if you are able to deploy the stent, just deploy it. Really, don't take it back. Avoid removal. Really, really try not to pull a stent back. If there is a justification to just put it in, deploy the stent. Thank you.
Thank you very much.